Next chairperson, Dr. Parasar, you can invite the next speaker, please. Dr. Parasar or Dr. Bijad.
Yeah, very much. First of all, sir, I must congratulate you for bringing in yet another very useful scientific program, which is so well appreciated. So it gives great pleasure today to introduce Dr. Khanna, cardiology from Sanjay Gandhi Institute of Medical Sciences, and is besides being a very accomplished cardiologist, has lots of papers on him when I was searching through Google. So without wasting much time, would invite Dr. Roopali Khanna to make her presentation and on biomarkers in heart failure, which is a very, very important test. Over to you, Dr. Roopali.
Thank you, sir. Good morning, everyone. And first, I would like to thank Dr. Mahapatra for giving me this opportunity to present on a very important topic of biomarkers in heart failure. So for next 12 minutes, we will just discuss about the biomarkers of heart failure with reduced ejection fraction. And coming to the first slide. So first and foremost, what is a biomarker? Why we are discussing about biomarker? So the biomarker is basically a biological marker. And the term was coined in 1989 to identify as a measurable and quantifiable parameter, which is used to assess the health and physiology of a patient in a term of disease risk and diagnosis. In 2001, WHO gave a little refined definition in which it said, it is a substance or a structure that can be measured in the body or its products and its influence or predict the incidence or outcome of the disease. So if we come to the heart failure, why this biomarker becomes important in patients with heart failure. So any substance which helps us in diagnosing the patient of heart failure or getting a prognosis or risk stratification, or which helps us in the treatment guidance in the patient will helpful in the way of heart failure. So what should be the ideal biomarker if you say? So in a general clinical practice, an ideal biomarker should be measured accurately. Whatever the diagnosis we want to make, it should be able to make it accurately. It should be easily available. The cost should be reasonable. And the reference limit should be defined in these cases. Rather giving a very vast reference range, a reference limit should be defined and it should have a low imprecision. That means that whatever the diagnosis it has to make in a proper sense. So the different biomarkers in heart failure can be antecedent biomarker. That means presence of the disease before it comes, we can diagnose that disease is going to happen. Or it can be used as a screening biomarker or a diagnostic biomarker. Then fourth important, it should help in the staging of the disease and prognostication of the disease. And the fourth and foremost will be your treatment biomarker, that whatever the treatment strategy which we are using, whether it is helpful or not. And as a surrogate endpoint telling us about the mortality and morbidity in these patients. So any biomarker to be available or to be utilized in patients with heart failure, it should be a thoroughly tested biomarker, easily measured, it should reflect the pathological pathway, and it should give an additional information whether before labeling it as a biomarker indications of heart failure. So coming over to the different biomarkers which has been evaluated in past 20 years, these have been defined according to the pathophysiology which they see. First and foremost, the most commonly used are natriuretic peptides, that is basically tends whether there is a chamber dilatation or myocardial stretch. It gives a release in these peptides and causing your heart failure symptoms. The second is here, which tells about the myocardial injury, the troponins which are regularly used in our setup. Third is telling us about the fibrosis or the remodeling in the patients. These are soluble tumorigenesis 2 and galectin 2 markers which have been evaluated. Certain neuroendocrine markers have been evaluated in the form of MR-ProADM, adenomedullins, and copeptins and endothelins. For the inflammations, we have HSCRP and interleukin-6, and renal injury telling us about the cystatin C and NGAL. Marker of oxidative stress in uric acid. So in next few minutes, I will tell about the few points of all these markers. The most common marker which was used is the natriuretic peptides. This natriuretic peptides, the commonly which has been used is BNP and NT-proBNP in our clinical setup. We all know these are released from the ventricular myocardium whenever there is stretch or remodeling. The BNP, pre-proBNP, they enzymatically degrade into proBNP, and this proBNP then differentiate into NT-proBNP and BNP, which helps us in the diagnosis of the heart failure. This measurements, the difference between NT-proBNP and BNP is basically NT-proBNP has a good half-life of 120 minutes, whereas BNP has a half-life of only 20 minutes. And the plasma concentration of NT-proBNP is 6 times higher than the BNP. The excretion is predominantly a renal excretions in NT-proBNP levels. And when they are elevated in the body, they basically causes natriuresis and diuresis in the patients of heart failure. So the first and foremost is to further diagnosis. So the NP levels, the was done by a first trial in 2002. This was a BNP study. What they did of 1,500 patients roughly coming to the emergency department with dyspnea, and they evaluated the BNP levels. What they found that the BNP cutoff of about 400 was very significant to rule out that the patient, the dyspnea is due to heart failure or not. So the diagnosis was helpful in this by BNP study. What about the NT-proBNP? The study which showed about the NT-proBNP study was the PRIDE study, which was done in 2005. It also evaluated the same patients coming to the emergency department. 600 patients were included, and they found if the level of less than 300, then you can rule out heart failure in these patients by negative predicted value of 99%. But there was a certain challenge that there was the age in these patients become important. If it is less than 50 years of age, the cutoff should be more than 450. But if it is more than 50, the cutoff becomes 900. So diagnosis is becomes important in patients of heart failure. This NP and NT-proBNP, they both gives us a good negative predictive and a diagnosis problem in these cases. So the different cutoffs have been evaluated in the form of your different trials, and the guidelines recommend in chronic heart failure, if it is more than 150 in BNP or NT-proBNP more than 600, it is heart failure is likely, whereas in acute cases, if it is more than 400 BNP or more than 900, the NT-proBNP, then a heart failure diagnosis is made. What about ANP levels? Atrial natriuretic peptides. These are usually taken whenever there is stretch. They give any additional benefit with BNP. There was a study which compared pro-ANP. They found that they give an additive value in patients in having an intermediate BNP value, but they don't have a over advantage of BNP. The only risk stratification study which was done with pro-ANP was in patients with ischemic cardiomyopathy, and they found that the pro-ANP levels have a predictor of arrhythmic deaths in these patients. So they don't give any additional advantage over BNP. What about the risk stratification? Can these natriuretic peptides be used as risk stratification strategy? So there was a study published in 2007, ADHERE registry, which they found that these patients, when they were the higher the BNP levels, the higher the in-hospital mortality in these cases is there. It was a registry done in 48,000 patients. What about the pre-discharge natriuretic peptides levels? The pre-discharge natriuretic peptides gives a better predictor for the mortality and the prognosis in these patients, which was studied in the optimized heart failure study. Can we guide the therapy according to the natriuretic peptide levels? So that's a big challenge, that if the natriuretic peptide levels are we decide the treatment depending on the NT-proBNP levels. This was shown in 2017 that if we decide the treatment according to the biomarker guided as compared to the usual care, there was no significant difference at the 2 years of the end of the study. So still the natriuretic peptides are not used for guiding the therapy in these cases. A little one point would be there, since naproxen inhibitor are commonly used, the BNP levels gives a falsely low levels in these cases, high levels of BNP, because the naproxen is used for the degradation of BNP. So the NT-proBNP levels should be used in patients who are ARNI. There are certain confounding factors which I told, which might increase the nitropeptide levels in these cases, should be kept in mind. And there are certain confounding factors which might decrease the nitropeptide levels, which has to be kept in mind whenever we are going to see these patients. But despite these limitations, the current status of nitropeptides is a class 1 indication. This should be done in the patients for diagnosis, for monitoring, and for prognosis in these cases. What about the other biomarkers which can be used? The second biomarker which has been used widely is galactin-3. It is basically produced by macrophages, and it helps in fibrous remodeling. It is not helpful in diagnosing acute heart failure, but it is a good predictor for rehospitalization in patients with heart failure, which was shown in the GALA study. The SS2 in a biomarker is a suppression of tumorigenesis ligand 2, and it is basically a biomarker for left ventricular hypertrophy and ventricular remodeling. It can be used for your health risk stratification, but still not good in use for your diagnosing heart failure. So this was a score which was developed, which was see the ST2R2 score, and they found these patients for reverse remodeling. This ST2 levels, if it is less than 48, that causes a good remodeling in these cases. The troponins we all know tells about the myocardial injury, so they can be helps in your diagnosing the cause of heart failure, and HS troponin can be used for the prognostic stratification in these cases. Other biomarkers, more small studies are there, still not in clinical practice, which we use are adrenomedulin, cystatin C, copeptin, endothelin, and growth differentiating factor 15. These all studies have shown that these have prognostic significance in these cases, but still not in our routine practice. The most important newer trials are being done on genomics. That is, say, if we target the genes levels of these patients of heart failure, we can identify these patients of high risk and might change the natural history of the heart failure, but still these are the hypothesis, and it's a more a lab data, not in the clinical practice, which we can use. The same way microRNA are being there evaluated in the studies, so we can prognosticate and change the biomarkers. What about the multi-biomarker approach? Can a single biomarker is sufficient, or do we need a multiple biomarker which can help us in better risk stratification? So this was a very good study, Reflex Heart Failure 2017. It basically 1,000 patient studies which stored patients of heart failure and evaluated 7 biomarkers in a cases, including NT-proBNP, HS troponin, soluble ST2, growth factor differentiating factor, cystatin C, and galectin-3 and HSCRP. Yes, so they evaluated at the level of day 2, 5, 14, and 16 to see the primary outcome of a cardiovascular mortality at 180 days. And they found, except galectin-3, all the biomarkers, when they were measured at day 2 or day 14, they have a better predictive value for cardiovascular mortality. We use in the patients who have high risk for stratification and prevention. So what does the guidelines recommend? The guidelines recommend the BNP class 1 indication for diagnosis. For prognostic, it is class 2A, high sensitivity troponin, class 1 by ESC, and ACCCA, SS2, and galectin-3 are still class 2B. ESC do not recommend it for in heart failure patients. So in concluding, so still the biomarkers, there are many, but BNP and NT-proBNP are the gold standard in these patients for the prognostic, diagnosis, and stratification. The role of NP as treatment guiding therapy is still unclear. High sensitivity troponin and soluble ST2 are currently the most promising biomarkers which can helpful in prognostic stratification rather than the diagnosis. And a multi-marker panel or scores can be used in patients with high-risk heart failures for stratification. There are different genomic techniques which are underway which can help us in the future research. Thank you.